Apologies, everyone. One moment.
You were just testing us, right?
Yes, no, unfortunately, my Chrome just cut out, but that is okay. I'm going to go ahead and play everyone the intro video. Thank you for your patience.
Hello, I'm Christy Cade with the White Ribbon Alliance.
And I'm Cindy Garcon, Coalition Director of the Self-Care Trailblazer Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone: advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Trailblazer Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee, Advanced Family Planning, JPIGO, PATH, Population Services International, and most of all, White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Hi, everybody. I want to take this opportunity to really welcome you to this incredible session, which will be self-care and universal health coverage. And health self-care can help ensure that nobody is left behind with universal health coverage. We have over 100 people registered for this webinar, and we have a great lineup of speakers. My name is Malaya Harper, and I'm the Director for Sexual and Reproductive Health and Rights at Engender Health. Before starting, I really want to do the most important thing, which is communication, and make sure that everybody is listening to this in their language of choice, English, French, or Spanish. So if you follow this slide, when you're in Zoom, you'll see at the bottom a little globy thing, and you can click on the interpretation button and select English, ou Français, ou Espagnol. You will then hear the translated audio in addition to the original language. If you'd just like to hear the interpreted language, please click mute original audio, and then you'll be able to hear just in the interpretation language. I'll give everyone a few seconds to be able to click on their language of choice. Okay. I hope you're listening now in your preferred language that we offer. I want to remind everybody that this meeting is being recorded, and please stay mute unless you're speaking. We have the chat box. We can see 65 people have joined already. We don't have the opportunity to introduce everyone personally. So I'm going to ask, please, if you can put your name and your designation in the chat box, then people can start seeing who we have on board here. I'm going to kick off right now. We're going to kick off with a little Zoom poll, okay, just to get things going, to see how you would characterize your perspective on the role of self-care in achieving universal health coverage. How, you know, and you can think, are you skeptical? Are you not sure? Just throw in some words, single words, into the upcoming Zoom poll, which we're just about to launch now.
One moment. Thank you for your patience. Nanake, if possible, could you launch the poll?
So here we go. Are you a fierce advocate? Are you still deciding? Are you somewhat skeptical? Submit your responses so that we know where we're standing here.
It seems like we have a small delay with the poll. I'm sorry about this. One moment.
That's okay. While we're waiting for the poll to get up, I did forget to say, as you introduce yourself, you'll also be able to put questions and comments in the chat, and there's going to be 2 opportunities for Q&A during this session, as well as an opportunity to go through the breakout group. And if we can't do the chat, that's okay. You have an opportunity at the, if we can't do the Zoom poll, we'll have an opportunity for a word cloud at the end. So let's just hear from the organizers whether we're managing to get the Zoom. Oh, isn't that great? We have some clear alignment here around people being fierce advocates, but we also have skeptics, people who are still trying to figure out where they sit here. And so we really want an opportunity to get a diversity of opinion and thoughts during this session. Now, before we turn to our speakers, I just want to give an opportunity really to give an overview on this session and what we hope to explore with you here. And we really, during this session, we'll be looking at how self-care is a fundamental part of primary health care and how that can be an essential element of helping countries achieve universal health coverage. We're going to examine a little bit on what accountability looks like using the lens of adolescents and young people to ensure that nobody's left behind. And we'll be looking at some of the mechanisms that are necessary for universal health coverage, in particular, financing both of universal health coverage, but also the costing of self-care. And we'll also be looking at how some of all of this can consolidate into what's called the Universal Health Coverage Health Benefit Package. And someone will be joining us to explain that process. As I mentioned, there'll be 2 opportunities for Q&A, which we'll try to triage. And before I turn to our opening speaker, I want to give some framing for universal health coverage and the context, because I know the audience is comes at this agenda from different perspectives. So everyone everywhere has a fundamental human right to health. And achieving universal health coverage means that all individuals and communities receive the health services that they need without enduring financial hardship. And as we'll see, those 2 phrases, need and financial hardship, are really the core of universal health coverage. So in essence, it's a political choice based on rights closely linked to health for all, and equity is at the core. There's really strong global commitment for universal health coverage, both in the SDGs and in the political declaration in 2019 at the UN high-level meeting, which is widely seen as one of the most ambitious declarations in health in history. So what we're helping to do here through this webinar, and people around the world through different processes, are to find a way to translate that political commitment to action. And the current global crisis, the pandemic, really reinforces this need more than ever before. Marginalized, vulnerable groups we know are the hardest hit by the pandemic, and they suffer the least access to healthcare during the pandemic. The pandemic has also helped kind of bring to the forefront the visibility around self-care has kind of exploded onto the scene. So what can we all do to make this vision a reality? We need to keep in mind that universal health coverage is an outcome, and primary health care and self-care are an approach to help get us to that outcome. So really here we're discussing whether self-care is the most cost-effective way of putting care into people's hands and helping us achieve UHC. We also know self-care is tremendously transformative in terms of gender transformative and central to empowering communities. So both UHC and PHC are intimately embedded in building strong health systems, and self-care should be as well, not as an instrument to bypass the health system and free governments of their responsibility, but essential to it. So without further ado, I want to introduce our first speaker, Shannon Barkley, who's the technical officer in the special program on primary healthcare at the World Health Organization. And she leads the work on evidence and innovation. She's got an incredible academic foundation, and throughout her career, she's been involved with the development of effective primary healthcare among underserved communities globally. And so, Shannon, with those few words, we'd love to hear your framing presentation on PHC self-care and the achievement of universal health coverage.
Thank you very much, Malaya, and thank you all for the opportunity to be here to speak to you a bit about our work at WHO and how in the global community we see these concepts being tied together. As Malaya rightly indicated, my presentation is going to focus today on how self-care within primary healthcare is critical to advancing the UHC agenda, including why primary healthcare is important as the backbone of the health system, some evidence to support the importance of primary health care as well as self-care, and some WHO resources, initiatives, and next steps. I'll also touch briefly on the importance of partnerships in the UHC agenda. Next slide, please. As you can see here, universal health coverage means that all people everywhere have access to the health services they need where and when they need them without experiencing financial hardship. And so universal health coverage has really two essential elements: service coverage and financial protection. Primary health care, in turn, is the most effective, equitable, and efficient approach to health system strengthening. It does that by focusing on a rights-based approach, on principles of equity, and on solidarity. And so primary healthcare really is the approach. Health systems, applying that approach in health systems, are the means, and universal health coverage and the other health-related SDGs are our goals. We see self-care as an essential part of the PHC approach, and these commitments to primary healthcare at the Global Conference on Primary Healthcare in 2018, and its accompanying Declaration of Astana, as well as the political declaration at the UN high-level meeting on UHC in 2019, and of course, the foundational contribution and commitments in the Agenda for Sustainable Development, which runs us through 2030, are really foundational to help linking these ideas together and understanding their interrelatedness. Next slide, please. Our Director General has stated unequivocally that primary healthcare is where the battle for human health is won and lost. Next slide. And so in technical terms, primary healthcare really is a whole of society approach to health. It aims to equitably maximize the level and the distribution of health and well-being by focusing on needs and preferences as individuals and communities as early as possible along the continuum from health promotion, disease prevention, treatment, rehabilitation, and palliation, and as close as feasible to people's everyday environment. I just want to highlight here that as an example, you could think about heart disease. And really what this is saying is that we want people to be able to focus on promotion and prevention of heart disease as much as possible. If necessary, they can go on to treatment, if necessary, rehabilitation, and if necessary, palliative care. And in seeking those services, we want them to be available as close as feasible to people's everyday environment. And doing that, placing services as close to people as possible is really a driver for equity and accessibility. Advance, please. Primary healthcare has three main components, and this was codified in the documents supporting the Declaration of Astana. The first is meeting people's health needs through comprehensive promotive, preventive, curative, rehabilitative, and palliative care throughout the life course in services that are aimed at individuals and at populations in integrated health services, but integrated health services that are designed to emphasize primary care and essential public health functions. Secondly, primary healthcare systematically addresses the broader determinants of health, including social, economic, environmental factors, as well as commercial determinants and individual characteristics through evidence-informed policies and actions across all sectors. And we emphasize that component in multi-sectoral policy and action. And lastly, and perhaps most germane to this discussion, is the third component on empowering individuals, families, and communities to optimize their health at three levels. First, as advocates for policies that promote and protect their health as well-being. Second, as co-developers of health and social services in the management and organization of those services. And lastly, as self-carers and caregivers. So as you can see, primary healthcare treats self-care and caregiving as integral components of all efforts to improve health and well-being. For this to happen, individuals and communities have to have access to the knowledge, the skills, the resources required to meet their specific needs and sociocultural circumstances. That means they need financial resources, reliable information and technology, and when needed, trusted experts and allies to help them analyze information and navigate complex decisions and to advocate for them. The ability of individuals to make evidence-informed decisions and to take effective action is directly and indirectly affected by socioeconomic and environmental determinants, as well as by associated commercial factors that can be shaped by policy and action at the national, regional, and community levels. So as you can see, self-care is intrinsically linked to the other two components on multi-sectoral policy and action and the delivery of integrated health services. Next slide, please. So why primary healthcare? Evidence from a vast range of studies and decades of evidence demonstrate improvements in health outcomes. And those outcomes are as broad as life expectancy, cause-specific mortality rates, infant mortality, low birth weight rates, cancer detection, cardiovascular mortality. And it does all of that in a more equitable manner and more cost efficiently. In addition, it's been shown that applying a primary healthcare approach reduces the incidence of adverse events, as the number of providers that an individual sees throughout the course of their life is directly linked to the number of adverse events that they are at risk of. And amazingly, it has the potential to reverse some of the adverse effects of social inequality. We've seen in some settings that adding one primary care physician, meaning putting primary care really at the core of integrated health services per 10,000 population, can improve overall mortality by 3 to 10% depending on the cause. And that's true even after adjusting for socioeconomic and demographic factors. Interestingly, improving the supply of specialist physicians does not produce the same improvement in outcomes and does not produce the same improvement in equity. Next slide, please. As mentioned earlier, this commitment to empowering people and communities is included in the political declaration itself. You can see here the bolded statements where governments have committed to promote health literacy and work to satisfy expectations of individuals and communities for reliable information about health, and also a commitment to support people in acquiring the knowledge, skills, and resources needed to maintain their health or the health of those for whom they care, guided by health professionals. Next slide, please. And within primary healthcare, self-care is an essential element. As we heard in the introductory video, self-care is a quite broad definition in WHO. It's the ability of individuals, families, and communities to promote health, prevent disease, maintain their health, and cope with illness and disability with or without the support of a healthcare provider. I found the graphic on the left, which comes from the Consolidated Guideline on Self-Care Interventions from WHO, with the link included in the source below, particularly helpful. This graphic shows how health systems, in green, interface with everyday life, and that we call self-care. There are lots of words used in the literature to describe elements of self-care, and that includes things like self-awareness, including self-help, self-education, self-determination, self-regulation, self-testing, including here self-sampling or self-screening, even self-diagnosis, self-collection, or self-monitoring. And lastly, self-management, including self-management, self-medication, self-treatment, self-examination, sometimes self-administration, self-use, etc. And similar to primary healthcare, because in self-care, you're putting those delivery of services, the delivery of education really in the hands of people, as close to people as possible, you see similar improvements in outcomes. Again, you see improved coverage and access, reduced health disparities, and increased equity, and increased quality of health services, all at more cost efficient. Next slide, please. Importantly, self-care is visualized within integrated health services. So we don't really see these as two separate elements. We see them as a continuum. Self-care really forms the basis. Everyone the world round is performing self-care of some variety just about all day long, every day. Very, very few people go on to require super specialized hospital care or are able to access super specialized hospital care. And in the continuum, you have people who access more informal community care, you have pharmacy-based services, you have more formal primary care in either a community or a clinic setting. You have first level hospitals, referral hospitals, et cetera. And really, we want to see self-care as part of that ongoing continuum. And though this is envisioned as a pyramid to align to a lot of WHO's previous work, increasingly we're moving really to put self-care and primary care at the center of an ongoing process, seeing it as something that's cyclical and interrelated. And so people bounce from, entirely self-directed care to self-directed care in partnership with a trusted provider. Sometimes that requires ongoing referral to a specialist, but that specialist may prescribe even some self-care or new self-management mechanisms or new resources for self-education, and on the cycle goes. Next slide, please. Self-care is being accessed through a variety of platforms, including formal and informal caregivers, as mentioned before, some pharmacy settings, more standard health facilities. People are accessing self-care increasingly through digital technologies and platforms right in their community, sometimes through traditional medicine providers, sociocultural practices, at home, or through their family, partner, or friends. Next slide. Here you see the guiding document for primary healthcare, the operational framework for primary healthcare. On the left, you see the approach to PHC, which was described earlier with the 3 components. And the important element here is really in the center. It's the levers of primary healthcare. And you can see here there are 14 levers. 4 of them are strategic, foundational levers, things like political commitment and leadership, governance, and policy frameworks. And 10 of them are operational levers, things that require a bit more of an implementation or operational aspect, things around models of care, health workforce, infrastructure, medicines and health products. And you can see that each of those results in the improved results that we've described earlier, and ultimately universal health coverage and the health-related SDGs. Next slide, please. Now, each of these levers are essential to enable self-care. There is not a single one of them that is unrelated to the self-care element of primary healthcare. For example, political commitment and leadership. There requires a recognition of the importance of self-care as part of the health system response and enables the foundational aspects to allow self-care to move forward in governance and policy frameworks. And governance and policy frameworks are necessary to allow for self-care aligned to national objectives and guidelines and best practices. And that means sometimes changing the regulatory mechanisms or access elements to things like diagnostics and medications as appropriate. I'll jump down just for a minute to engaging communities in how self-care modalities are developed, how they're rolled out, how we communicate about self-care interventions with the more formal health service network. Health workforce needs to be supplied with appropriate competencies, meaning skills, knowledge, and attitudes to promote self-care and also to support self-care and interface with self-care as appropriate. Digital technologies are providing new access to information, new diagnostics, and new communication avenues all the time. And so as you see, those are just a few examples of how these levers can support self-care as they're rolled out, but it also speaks to the complexity of self-care and the number of foundational elements that are needed to be put in place to enable self-care as part of primary healthcare. Next slide.
Shannon, we have about 30 more seconds.
Excellent. These are just a few examples of COVID-19 and self-care. And you can see here, as mentioned in the introduction, that for various reasons in the COVID-19 context, self-care has become more visible, more needed, and it will set the groundwork for enabling some leapfrogging of effective self-care in the future. Next slide. And lastly, just a quick note on partnerships. I wanted to mention UHC 2030, which is the broadest coalition for UHC, bringing together partners, a range of international partners from international organizations, NGOs, governments, really to strengthen political commitment for PHC and UHC, and offers an opportunity for joint working, shared experiences, accountability, and shared advocacy. And also the Global Action Plan for Healthy Lives and Wellbeing, which brings together primarily UN-affiliated family agencies to promote primary healthcare on the way to our health-related SDGs. And so we welcome the involvement of additional partners in these platforms and to use them as appropriate to their work plans. Thank you very much for the opportunity to share.
Thank you so much, Shannon, for a really fantastic introduction to the importance of really looking at self-care as embedded into primary healthcare and how that contributes to the outcome of universal health coverage. I'm asking everyone, please, if you have questions for Shannon, we have a couple minutes, so 1 or 2 questions to her or myself. And while we wait for them, I would just say that often with what I love about this presentation is when I speak with the self-care community, we often see it as a technology. And when I speak with the universal health coverage community, we often jump to financing or health benefit packages. And so I think that was a brilliant way of actually showing that system around equity and empowered communities. We have a question from Muriel Snyder to you, Shannon, on which is the biggest challenge in ensuring that self-care is embedded in PHC?
It's a great question. And I think the challenges, much like the challenges to the health system, are varied depending on the context. I think some common themes that we see would be around really the governance and policy frameworks that enable access and appropriate regulation of information, of technologies, of medicines and products. And then that's very closely linked to health workforce and health workforce training, ensuring that as people interface with the more formal health sector, that the things that they're already doing in self-care are supported, that health providers have a positive relationship with ideas around self-care, that they have a recognition that people are performing self-care all the time, and that it's only a very tiny, minute portion of their life that they're actually interfacing with the more formal health sector, and that providers have a healthy understanding of where they fit in that ecosystem. But that takes training in pre-service and in continuing education to make sure that they have the right foundational base philosophically and understanding, but also that they achieve the right competencies as new technologies, new medicines roll out that enable self-care, that they feel comfortable rolling those into their practice. I would say those are probably two of the most common ones, though there are many others.
Great, and we're going to sneak in one extra question here before moving to the next panel, which is, do you have specific examples you can provide on how PHC can lead to reduced social inequalities and how self-care could be fundamental to that? And thanks for that, Kimberly Whitke.
Yeah, Kimberly, there are actually quite a few reviews that have been done looking at the orientation of health systems and how primary healthcare oriented the health system is, that demonstrate that the more oriented a health system is toward primary healthcare, the more balanced or even more pro-poor, to speak more bluntly in some studies, the outcomes tend to be. And so that health spending tends to be more directed to impoverished populations, in particular in health systems that are more PHC oriented. And additionally, you start to see some equilibration of some of those health outcomes. And things as base, they tend to be environmental studies. So things like where more providers were introduced for primary care, you start to see some of the balances in things like maternal mortality or infant mortality earlier than in places where they tend to overemphasize specialty care. And how self-care nests within this, I think it really speaks to that need to put care close to people. I think in general, in primary care, speaking as that element of the integrated health services, providers tend to be trained in a bit more of a biopsychosocial model, and they understand, because they primarily see their patients in an outpatient setting, they have a very realistic expectation for what those very short visits can accomplish with individuals. And they recognize that it's their role in that very short visit to give people the skills, knowledge, and resources that they can and sort of partner with them in a more longitudinal way. And so I think self-care becomes a very natural part of the primary care and therefore primary healthcare orientation of the health system.
Thank you so much, Shannon. And I think we'll have an opportunity both through the breakout and in the other question and answers. If people, some thinking comes, we'll circle back to you, Shannon, but thanks so much for laying that groundwork. And I think it's a perfect segue to our next speaker, because you really framed, Shannon, how both equity and empowered communities were central to both universal health coverage and primary health care. And by the same token, then, if we're integrating self-care into the primary healthcare arena, then equity and ensuring that no one is left behind is central to self-care as well. And sometimes in the community, we're not always talking about the equity lens to that. So our next speaker will really be talking about leaving no one behind from the perspective of adolescent and youth inclusion. And she's Bella Bayu Roman, and she's with Engender Health as the gender youth social inclusion advisor in Ethiopia. And that's the context that she'll be speaking to. And she comes to us with more than 10 years of experience in both the development and humanitarian programs, and has worked on a variety of programs related to maternal, child, and youth health. And she'll take us through really what the opportunities and the challenges are for adolescents and youth within the context of self-care in Ethiopia. Thanks very much, Bella. Over to you.
Thanks, Melia, for the introduction. Hi, everyone. I'm going to give you a brief highlight about the self-care interventions for the AYSRH, for the adolescent and youth health community in the Ethiopian context. Next slide, please. Next slide, please. Next slide.
Sorry, there might be a
We
little.
might be having a tech thing, so let's, oh, there it is.
There it is.
Thank you.
Thanks. So Ethiopia has a population of more than 100 million. From this, adolescent and youth population is around 42%, with almost equal male-female ratio. And adolescent girls make up almost 1/4 of the total women population, and they account for almost 12% of all births. And in this adolescent girls, young early and forced marriages are very common. So they contributed, like more almost, 13-12% of all births. So almost half of the pregnancies in adolescents in Ethiopia are unintended, and 46% of those unintended pregnancies end in abortion, and mostly unsafe ones. So our universal health coverage is around 39%, which is very low from our target. And to achieve universal health coverage in the Ethiopian context, the primary healthcare system is our core in the delivery of health services. And the public sector is the important source of healthcare. So we have health extension program, which is a people-centered health approach, which engages the community through the health extension workers, through community engagement, and through household facility levels to increase the healthy living lifestyles and health-seeking behavior among the community. So the private-public partnership is another way to achieve universal health coverage, and also to address the financial issues. We have community-based health insurance, which is at the community level to raise funds as an insurance for the majority of the rural communities. Next slide, please. Again. So the importance of self-care in the Ethiopian context is the government of Ethiopia and partners working on self-care believe that it ensures empowerment of women and girls to access quality SRH care and information. And also it ensures privacy and confidentiality. And also it increases existing networking in the primary healthcare units. So to achieve these major goals, there are lots of opportunities, and some of them are the primary healthcare system is the backbone of our healthcare approach. And there is a real interest and political commitment from the government of Ethiopia to implement self-care interventions in the COVID-19 time, and also in the humanitarian context where mobility is somehow restricted and health facilities might not function at all contexts. So there is a real interest to use self-care intervention as a service modality in addition to the primary health care. So there is an enabling policy and policy environment. The government of Ethiopia is like following the adolescent and youth health strategy to address all adolescent and youth health needs beyond SRH. So in that guideline, it's under the process of revision. The first term is already due. And in that revision, self-care is mentioned as one of the strategies to reach adolescent and youth. And also in the health sector transformation plan 2, which will last from 2021 to 2025, self-care approaches mentioned as a great component to reach adolescent and youth and the wider community of Ethiopian through empowerment and engagement. So some of the expected and anticipated challenges are maybe financial barriers, because the government of Ethiopia may not support all the stocks needed for out of pocket. So, most adolescents and other vulnerable groups might be left behind, and it might widen gaps. Policy and legal frameworks, implementation to address life skills education and contraception and other SRH information may not be equally addressed across all the nation. Rural, urban, educated, uneducated, pastoralist, agrarian, and such kind of inequalities might, widen. And also widening inequalities in certain areas, self-care interventions might not be, applicable. So these are the anticipated challenges regarding self-care. Next slide, please. Thank you. This is my short presentation regarding Ethiopian context and self-care for adolescent and youth. Thank you, Malia. Back to you.
Thanks very much. There's a hugely rich context here that Bella mentioned, and what we're going to ask you to do is you can put your questions in the chat now, but we'll hold them until we have 3 other speakers, and we'll take all the questions at the same time. But so as not to lose some of the targeted questions on the gender transformative impacts and the youth inclusion for self-care, you can start popping them in the chat now, and we'll be able to capture them. I think it's important that we often don't think that self-care, if not done properly, actually has the risk of widening inequalities. So I think Bella mentioned an important context, and also how we need to get the policy and legal framework right for its inclusion into UHC. I'm going to turn to our next 2 speakers, who's going to pick up a thread that Bella mentioned. They're both on the financing for universal health coverage, as well as the costing for self-care, because the important thing on UHC is that tagline at the end, without financial hardship. That's how we know that we're going to be reaching universal health coverage. So the first speaker for this section on financing, who pays for self-care and how, is Nelly Wakaba. And Nelly is a global health leader whose mission is to make access to care a reality through strategic health programming, innovative financing pathways, strategic partnership with governments and other key stakeholders. She's worked with a wide range of people, from the Global Fund to the Changing Diabetes in Children program across 10 sub-Saharan African countries. And she's currently leading the country engagement and support work for the Financing Alliance for Health. The speaker that will come directly after her, and I'll introduce her now, is Mercy Mvundura. She has a PhD in health economics, and she's working as a technical advisor for PATH with over 10 years of experience leading the design and conduct of economic evaluation of healthcare program interventions and technology. So she leads a lot on costing work and cost effectiveness work across a variety of countries. And she's going to directly follow Nelly by speaking around the costing elements of self-care. So with that, I'm going to turn Nelly to you for your presentation. And we have with this section a total of about 15 minutes between the 2 speakers. Thanks very much.
Thank you very much, Malaya. Thank you very much, everyone, for giving me this opportunity. And I will now take us through the health financing. Who pays for self-care? And how do they pay for self-care? And what are the bottlenecks? And as you can see, these 2 Maasai ladies from one of the counties in Laikipia, called Laikipia in Kenya, they are discussing, actually, self-care matters, because self-care goes to the community. So let's see, how does this happen and who pays for it? Next slide. And so we're going to just look at the context and what are the major challenges the countries are facing in scaling their care, their community and primary healthcare systems, and also what are the key considerations that countries can make towards financing and sustaining these systems. Next. And as you've heard, self-care is the ability for you and I, for my grandmother in the village, for my grandfather in the village, for our children to be able to take care of their health, to be able to prevent disease with or without the support of a healthcare provider. But if we look on the graph on the right, and looking at the trend of the value of UHC, Service Coverage Index, you can see that there is clearly some inequality in terms of the UHC coverage in some of these areas in the world. And of course, the low income and lower middle income countries are lagging behind when it comes to self-care. And what that really means is that not everyone is actually able to access care. And so through the definition of UHC, that we are leaving no one behind, we have to think about what are these bottlenecks that are preventing people from accessing care wherever they are without financial barriers. And your guess is as good as mine. One of the biggest puzzle and the elephant in the room is financing. And so if we are to accelerate or even maintain this progress, we have to need sustainable and greater investments in community and primary healthcare. Because with self-care, we cannot leave the community behind. But if this trend continues, unfortunately, we'll only have a paltry 39 to 63% globally who are able to access essential health services. And so to reach these SDG targets, we need this coverage to at least double. If we are currently at only 41% in low middle income countries, for example, we need that to double by 2030 if we are to achieve our strategic sustainable development goals. And so I will quote Dr. Tedros: if we are truly serious about achieving UHC and improving people's life, we must get serious about primary healthcare. Next slide. So then what are these major challenges? What is the issue? Why are we not scaling our community and primary healthcare services, and especially in sub-Saharan Africa? So there are three major things, and one of the key things that we'll focus on today is financial sustainability. And to just put a context to this is that Africa accounts only for 2% of the total global health spending on healthcare, a paltry 2% only. And on average in Africa, the out-of-pocket expenditure is atrocious at 36%. Where the domestic funding stands at 35%, and the donor assistance for health, which is actually dwindling, is at 22%. And so with this context, these are the major bottlenecks in financing these systems at scale, because we are saying, if we are to reach everybody, if we are to leave no one behind, then we must scale up these interventions, not in one district or in one country, but we must scale up these interventions. And so what are these bottlenecks? I coupled them in four main areas. One is the level of funding. It is insufficient. The donor dollars are declining, and then limited domestic financing. The second layer of things is that even if there is money, there is inefficiency in terms of the funding. One is the fragmentation. So one donor brings, another donor brings at different times. So there's a lot of fragmentation and verticalization. As long as we continue to verticalize, we are going to have very high transaction costs in terms of even getting this money to these countries. We are going to have inefficiencies in terms of implementation. So you find there's duplication. Why? Because of fragmentation. You find there is too much admin cost. Why? Because of fragmentation. And then the last thing is not maximizing on the existing funding opportunities. I have seen countries where I have worked, they have gotten money from Global Fund, for example, but then their burn rate, because of their inefficiencies, is very low. So then even making the case for more investments for primary healthcare becomes very difficult. The third bottleneck is the architecture of existing funding. There is misalignment in terms of timing and funding. And we shall see an example of a country where the timing of the funding comes when maybe the primary healthcare plan has lapsed, or it comes right in the middle of implementation. Applying for that funding again becomes also a very atrocious process, that this funding then becomes very difficult to access. Erratic and unpredictable funding. Today there's this money, tomorrow it's not there. And suboptimal programming, as I was saying, and public financial management. There is worrying accountability in some of these countries that we are implementing these programs, and these continue to demean the achievement of UHC. Lastly, other key confounders that we cannot run away from is that countries are facing limited fiscal space, and the pandemic has not made things even better. And then number two, also, countries are servicing debts, especially in the continent where I come from. Some are even defaulting on those debts. So when you're trying to make a case for investment in self-care and PHC, then the competing health priorities really cause a major bottlenecks when it comes to financing. Next slide, please. And this is just an illustration. I'm sure when you look at this slide, you know, your mind goes, you almost feel dizzy. And this is a typical practical situation that countries face because funding is fragmented, it's unpredictable and difficult to manage. And this is one of the countries where we support. And they have this amount of funding, yes, but you can see the web. It comes from this partner who channels through here before it gets to me, who is implementing PHC and self-care activities. It's too late. I can't even implement. That is one layer of it. The other thing is that getting this money also is very tough for some of these countries because there are different timelines and different processes and different requirements. So this is just an illustration of what it means to really access this funding, both domestically from donors or other innovative financing mechanisms in terms of being able to execute these programs. So one partner requires a certain strategic plan, another one needs approximately 3 months, another one needs 6 months. So by the time you're done and money lands on the account, in the account for you to implement, you barely have time to actually execute. And these are the bottlenecks that we need to address. Next slide, please. So then, after all is said and done, we need to achieve universal health coverage. We need to finance primary healthcare. And so what is the approach? What can countries do? What can countries consider? And at the Financing Alliance for Health, as we support governments, this is some of the key considerations that we use as an approach for countries to support to finance their community and primary healthcare. I think the first thing is political prioritization.
You have
Yes?
about 45 seconds.
Yeah, it's the last slide. Thank you. The first thing is political prioritization. We cannot run away from political economy. Health is political. Decisions are made politically. And so we work to build those champions. We work to continue to advocate at the political level for us to have traction. Second thing, policies and costed strategies. Third thing, can we map the existing resources? Where are they going? Where they're coming from? And what's our gap? And lastly, a very critical document for advocacy, which is an investment case. We have been able to demonstrate the value of community health, both in terms of impact of economic returns, social returns, and health returns. And so these are the things that we need to document and use and help countries to mobilize resources. So thank you very much. And I believe that this conversation will be helpful in seeing how countries can change the landscape. Thank you.
Nelly, that was fantastic and a great build on when Bella was talking about how young people pay out of pocket to access self-care. And you really, I think, helped us with both the massive ask that we have, but also the huge bottlenecks. And I love how you then wrapped it up on how we need to both think differently and do differently at the end. Mercy, I'm going to turn to you because I think your presentation builds really nicely on Nelly's around the economics and financing considerations for self-care more specifically. So I think we have 3 great presenters feeding off of each other. And please do put your questions as they come to your mind into the chat.
Thanks, Malaya, and thanks to Nelly for setting the groundwork on this continuing presentation around the economics and financing considerations for self-care. Next slide, please. So as we think about the key considerations, there are three main buckets that I would say are important. The first is asking the questions around efficiency, and you've heard some of these terms already in earlier presentations. With efficiency, we are asking what are the user and health systems costs and benefits associated with self-care. So we're not only concerned about cost to the health system, but we're also concerned about costs to the user. Secondly, the second bucket is around financing, and that's asking the question about who pays for these services and interventions. Thirdly, it's asking about equity, who accesses the self-care interventions, and I'll explain in more detail in the subsequent slides. Next slide, please. So when we think about efficiency here, self-care interventions need to be evaluated to assess their impact on costs to the health system and to users, and also not only cost, but also the health impact and health outcomes. So a self-care intervention can it can reduce costs, it can result in no change in costs, or it can increase costs, again, to both the health system and to users. And an intervention can impact health outcomes. It can either improve them, it can result in no change, or it can actually worsen health outcomes if poorly designed. So interventions that should be implemented are those that reduce costs and result in no change or improved health outcomes, or those interventions that marginally increase costs but improve health outcomes, that is those that are cost effective. And so on this visual, these are the interventions shown in green. And as you can see, where there is improved health outcome and increased costs, we have a question mark because some of them end up not being cost effective. The value for money is not there. And so again, interventions that worsen health outcomes or increase costs, but worsen health or no change in health outcomes should not be implemented. And so again, economic evaluations can help to identify where an intervention sits within these buckets. Next slide, please. So here I want to just provide just an example of an evaluation that we did a couple of years ago between 2015 and 2017, where the objective of this work was to evaluate the costs of a self-care intervention, where we compared self-injection of an injectable contraceptive compared to provider administration. The providers could be facility-based or they could be community-based. So in this study, we collected primary data in 2 countries that are represented here. The study was actually done in 3, but we actually just show results from the 2 countries here. We looked at comparing the interventions. We looked at different types of costs, including the direct medical costs, which are the cost of the contraceptives themselves, the provider time, and also when there was community distribution, looking at the travel costs for the community health workers. We accounted for the cost of medical supplies, costs for drugs for treating side effects, and also the waste disposal costs for any of the medical supplies that were used. We also, in this study, evaluated the cost to women, which are their travel costs and also their time costs to travel to receive services. And for self-injection, we also included costs for self-injection training. So what we found from this analysis, and again, this is a manuscript, a published article, the citation is at the bottom. The results that we found from this study was that that total costs for self-injection were lower than for provider administration at facilities, and so a self-care intervention reduced costs. Secondly, we also found that self-injection reduced the costs borne by users, and so that was again just an evaluation, because we did this study because it's not obvious that an intervention is always going to reduce costs. And so we wanted to have evidence on what those implications were. And as mentioned again, the self-care intervention, which was self-injection, actually resulted in reduced costs to both the health system and to users. The total costs were lower. So again, just an example of an evaluation done, economic evaluation done on this topic. Next slide, please. I'll move back to the buckets that I talked about in the initial piece. Looking now at the issue of financing, and Nelly has spent quite some time looking at this. And so with financing, again, we're asking about who pays for the intervention. They can be different payers, and they can be a mix of payers. It necessarily doesn't have to be one payer. Governments can be payers, donors, whether they are local or external, can be payers, health insurance, the users can be payers, and there can also be other payment mechanisms and other payers in the mix. So findings from costing studies have shown that for most health services, the direct medical costs typically account for a larger proportion of the total cost. And so a major concern with self-care is that it may result in cost shifting from the healthcare system to users paying out-of-pocket costs. And as Nelly mentioned, the out-of-pocket costs can be burdensome and is already large in some contexts. So it becomes especially important to include financial protection mechanisms when self-care programs are designed to ensure that there's no shifting of the financial burden to users, as this may negatively impact access. Next slide. So the last bucket is around equity, and it's really asking about taking into account how does the intervention impact access. We know that access to services or an intervention depends on the knowledge of the user, the complexity of the intervention, the location, geography may impact access, social factors, the income level, age, and other factors. And so self-care interventions have the ability and potential to increase the reach of a health intervention and to increase equity. But there is need to evaluate how the intervention and program design impacts access and equity. And it is important to consider the populations that have demand-side barriers and to design interventions and services that reach these populations. Again, a clear thought process and evaluation in program design is important, again, to make sure that the targeted audiences are reached and the expected health outcomes are achieved. My last slide, in conclusion, next slide, please, is really highlighting that costing studies, economic evaluations can help to provide the information that is necessary to inform planning, to inform prioritization. Costing studies can also provide evidence. You know, as Nelly mentioned, budgets are tight. It is challenging to implement everything, even all the interventions that are cost effective. And so cost effectiveness studies can help to prioritize interventions and choose which ones have the greatest value for money, because again, with limited resources, it is challenging or impossible to implement everything. In addition, the information that is generated from these economic and financial analysis can inform benefit plan design, can provide evidence on financial flaws and prevent, again, that shifting away of the burden to the users. And what I'll conclude by saying, there are very few studies that provide this evidence. And again, this is more of a call to increase the evidence here so that, again, our benefit plan designs, our investment cases are generated using evidence from economic evaluations. I also want to just quickly point to a great resource that is available for those who want more information on this topic. And so it's this WHO report on economic and financing considerations for self-care. The link is at the bottom. And again, this can be available to we can provide a link through the chat. So that's the end of my presentation, and I hand it over to Malaya. Thank you.
Thank you so much. Great presentations, all three of them, and great framing. And now we have one last presenter before we move to the Q&A. And really, Patrick, you have the task now, the next presenter, of really looking at how we take this broad context that's been presented and integrate self-care options into national health benefit packages. So our next speaker, who's going to help us understand how to do that, is Dr. Patrick Kadama, who's the Executive Director of the African Platform on Human Resources for Health and the Director for Policy and Planning at the African Center for Global Health and Social Transformation. He has over 40 years of experience, and he's been an expert advisor at WHO in Geneva. Prior to that, he was the Commissioner for health planning and in Uganda. So Patrick, you have about 5 minutes, and then I encourage people also to keep putting questions in the chat as well en français. Vous pouvez mettre les questions dans le chat en français aussi, et on peut faire la traduction. Over to you, Patrick.
Thank you very much. I hope you can hear me well.
We can hear you.
My internet connection is a bit unstable. So I had to run back from office to home. And so I hope this will go well. Next slide. Next slide. Right here, I hope you can see this better than what I'm seeing, but this is a cube. This cube is the basis of a human aspiration where households access healthcare in totality, that the populations are all in access to care, that all services can be delivered to all, and that costs to clients, to households or patients who seek care are covered. This model does not work well in practice because of equity issues. Sometimes quality cannot be assured for all. And also there are issues that it is not possible to put together the money to finance everything. So here, these crude models to respond to this, I think they've been called crude models. They were really early models that we've learned about, the so-called beverage model, as opposed to the later model that based on social aspirations, which are sometimes called Bismarck systems. The social medicine is not very popular in some parts on one side of the Atlantic. The beverage model has been defined and refined and developed into an approach that has its advantages, but also certain disadvantages. So this crude model does not quite capture the complexity of financial sources, of organizational structures, allocation mechanisms, and other contextual elements that we face in reality when we are working on these health packages. So health packages will have restrictions. Hello? I hope that's not from my side.
No,
There
it's
will
not.
be
Please, can you mute yourself if you're not speaking?
One moment.
Sorry, Patrick. Please
So we
put
have
yourself on mute.
restrictions. So in considering a package, we have considered restrictions and targeting because we cannot cover the entire population. That is to your far left, the dimension at the bottom of the cube or on the side of the cube. The dimension in the middle of the orange cube, that we cannot cover all services. And so again, we have restrictions there. And in the vertical axis, we are unable to cover all costs. If you go to the next slide, here we can see what happened in Uganda because of such restrictions, but this happened everywhere. And it followed philosophies such as the philosophy that runs primary care. It's been better explained by the first speaker in better language. And moving into the package in the early 90s, we piloted a minimum healthcare package really driven by the World Bank. And it proved politically impossible to continue work with just 8 districts and a few, and we eventually abandoned that to expand it across the country, making the issue of coverage, the issue of quality, and the issue of cost even much more constrained. But the package helped to structure discussions and resource allocation. I think the biggest advantage here in designing the packages, as we've heard from the last 2 speakers, the various models we have for costing, the various models we have on casting value against monetary evaluations, because really money is a means of exchange between goods and service. In itself, its value has to have a human element and political element to it, but resources are absolute in that you need either a service or a resource to be in place. They will be limited to the extent they can be exchanged by the means of exchange, which we call currency or sometimes referred to as money. So the introduction of the package involved dialogue on concept and design and negotiations, delivery arrangements. It raised difficult human resource issues related to task shifting. There were big debates even after we moved into the next decade after structure adjustment. There was a lot of technical, I would call it professional resistance to task shifting. I think we've not gone over that, but these had to be managed sensitively, and there was a risk of losing professional support for the package if we went too far in one direction, leaving them behind. So to leave them on the table in the negotiation, we had to make compromises. It also influenced the debate.
Dr. Kadame,
Yes.
We have 1 more minute before we go to the Q&A, please.
Right. So
Thank
it
you.
also influenced the choices. And going on to the last section, because I was told I had only 2 minutes on each of these slides. First, in '93, we had the World Bank report, introduced a currency called dollars, disease-adjusted life years, which we used to model the packages. This did not work well because actually it's not a technical concept. It's a social context with a political influence. In the year 2000, we went further in that this young man, Joe Cousin, I think he's still there in WHO. Those of you who live around there might know him. He's a great man. He's a very, very clever man. He introduced system thinking to health financing models. And this now guides the thinking on health financing and planning by many countries, including the far right. It focuses on the function of care financing, which I'm not going to, revenue collection, pooling, and purchasing, and it has recently influenced the move towards what we call strategic purchasing of care. And in 2010, despite a lot of pressure, we had to leave out certain aspects to do with participation, to do with social health protection, and focused on health financing using this cube to show that inside it there is a smaller cube that shows actually the extent to which we have moved towards covering the entire population with quality services and ensuring that we are mitigating costs. Today, in 2020 to 2021, we got an unusual experience with COVID. COVID expanded the debates for consideration of self-care. Self-care, as was presented by the first speaker, is a component of the package, but it is actually the fundamental component of the package. In any household, before you do anything, before you access any other modality of services, you have self-care to extend to people who need care. And in a situation where you have a pandemic, an emergency, self-care becomes very important. And in this pandemic, we have an opportunity now to get back on the table the professionals who have also been a bit difficult and continue to be very much against self-care but often in situations like this, they have been with us in recommending self-care in the situation of people who are suffering with COVID, especially if they have very mild COVID or if they only need isolation. We have an opportunity to push the agenda for self-care. I'll not describe it, you already know it. So what lessons have we had? Key lessons have been that packages are useful when understood as political instruments rather than purely technical exercise. A word is missing there. It is purely, they are not purely technical. They are packages which are instrumental in political decisions to manage the 3 dimensions that we have just gone through that have to be negotiated. Secondly, packages can help the dialogue on priorities. When you are faced with those challenges, such as we have just heard from the Maasai in Kenya and in other situations in Uganda and similar countries, strive the care for better value for money is defined in a contextual way, using these packages to go towards satisfying the household needs. And lastly, packages can, in theory, and with close monitoring, also help to improve accountability. But packages on their own can include health self-care to the extent you have no access to other modalities for services that require skilled delivery. I'll stop there because 2 minutes is finished. 5 minutes is now gone. Thank you very much for listening.
Thank you so much, Dr. Kadama, for an excellent framing, bringing it back to the political context, but also the different philosophies over time that have tried to frame versions of health for all. And I particularly love the 3 key lessons that you had at the very end there. And the final one, which if we do this right, framing of self-care within primary healthcare and as part of UHC is a really important component of improved accountability if we get the model right. We have a few minutes for questions, and I'm going to turn to the first question that we have, which is going to Bella, right at the very beginning, talking about how we can leave no one behind and make sure that we're gender and youth inclusive. And the question here is, could you clarify the types of health issues that the Ethiopian self-care guidelines address? What are the types of issues within it? And which SRH services are within that? Over to you, Bella, and then a second question to one of the other speakers.
Okay. Thank you, Malia, and thank you for the question. Many of the SRH issues related with maternal and child health are addressed, like ANC, delivery, PNC, elimination of unsafe abortion, and also family planning, like with the self-injectables, over-the-counter OCPs and emergency contraceptives for adolescent and youth, male and female condoms. They are already there, except the self-injectables, but through the self-care with intensive health education and childbirth trainings and self-intervention for pregnancy-related pain and discomfort, pregnancy prevention, and things like that are heavily emphasized on that document. And also HPV self-sampling and STI self-sampling and things like that are also given an adequate emphasis. Mostly our interventions are, empowering service users, especially adolescent women and girls, to have that agency to exercise and seek and take control of their SRH issues. That's what the intervention would like to provide a huge emphasis. Thanks, Malia. I guess I answered.
Yeah, that's a great, very comprehensive answer. Thank you so much, Bella. Okay, the second question we have is, and it was alluded to, but we haven't spoken very much about it, is how can a global association support the implementation of a national program around self-care as part of UHC? It's a broad question, but we haven't spoken a lot about global associations. And I think sometimes we think of global associations are sometimes in opposition. So how can we work with global organizations to facilitate that? And then there's, I'm going to ask, I don't know, Nelly, if you've worked with global associations either and want to come in here. And then there's another question I'll pose before going to the group work.
Thank you for that question. I would say there, in the space we are currently working in, there are a number of associations that would be available to support countries at country level. And one of them is actually the Financing Alliance for Health, which is a global organization. And we do work with governments and countries to shape their policy and strategy for primary and community health, make sure that we have costed it, and inculcate sustainability, right? It's not an afterthought, but sustainability is thought throughout as they're doing the design and the planning, as well as develop an investment case. That's one layer. The second layer is there is something called the Community Health for UHC. It's a campaign. I'll put the link on the chat box. It's a campaign that seeks to support countries and work with countries to advocate for their community and primary healthcare programs, so that there is political will, there is traction from their leaders in terms of investment in community health. And as we have seen, community health and primary healthcare are the cornerstone of self-care. So I'm happy to put the link up on the box, and people can actually click and become, see details on how to join the membership. So that again is a global platform, but then gives access to countries to access information, opportunities for funding, opportunities to work with other people in this space. Over to you, Malaya.
Wonderful. Thank you so much. I think what I'm going to do now, what we're going to do is transition to the breakout groups, because it's going to give the highest number of people an opportunity to voice their issues and interests. And what we're going to ask you to do is use the information and perspectives you've heard today to reflect on your own experiences and how we can chart the way forward to self-care and UHC. So I'll start that transition now, and I ask people to really look at the chat where different links are coming in with different resources as well. And I'll see you back here in about 20 minutes.
Right. Before we move out into breakout rooms, we do have French and Spanish breakout rooms available. So you are going to be placed into an English room unless you have otherwise noted in the chat when I have reached out. If you would like to change to French or Spanish room, you simply can message me. My name is Natalia Buchwald. I am the tech support. And you can go ahead and also move directly to that room of your choosing with the Zoom breakout room feature. So with that, I'm going to go ahead and place you in your rooms, and let me know if you have any issues with the chosen language.
I'll wait just a couple minutes to get everyone back in the room, and then we'll jump in again.
I think we should be all set.
Natalia, do you know if the breakout rooms have all closed?
Yes, we should be all set.
Excellent, thank you, everybody. I hope that was a little bit of fun. I certainly loved the opportunity to be the skeptic and naysayer. And I want to really thank all the fabulous presenters for, I think, what was a very rich session. And there's a recording available and lots of tools in the chat. We don't have an opportunity to present back from the breakout groups, but I think I can give a little bit of a reflection in terms of what I heard in the session itself. And I just want to walk you down the recent past of memory lane, where we started with what self-care is, and it's a more expansive definition, I think, than I had originally thought. And I thought Shannon from WHO did a great job of framing how, if we include self-care we need to include self-care into primary healthcare and into universal health coverage, and why that framing for us is really important. And Bella moved on to talk about the gender transformative and youth inclusive potential of self-care, and what things can look like when you have a favorable policy environment, but also some of the constraints in doing that, and some of the risks that self-care could actually grow inequalities. And I want to thank both Nelly and Mercy for really, I think, the reality. When we sit in the self-care community, we talk about getting the information and the evidence, but if we really are going to have self-care as a vehicle for driving universal health coverage in key areas, then we really need to look at the current financing context, which is very complicated, the financing for UHC, as well as the bottlenecks and how we do things differently, as well as the costing of self-care interventions itself, the evidence that shows us that this is a more cost-effective way of getting the outcomes we seek, and making those arguments. And then finally, Patrick Kadama talked to us about the different frames, how it essentially it is political and philosophical, and there's been different attempts to have this conversation before, and the three key lessons that he left us with. I think what kept coming back to me through all the sessions was really how self-care has the power to put the U into universal health coverage. So the universal elements, how we really can support communities to have the services that they need and deserve, and the equity considerations that are coming back through all the conversations that we had this afternoon. I really enjoyed the group work and some of the skepticism, and I think it's really important that moving forward with the discussions on self-care and how we integrate it properly into universal health coverage, that we bear those in mind. That it's at the end of our discussion, there was somebody who was talking that it's really a whole of society approach, and we can't forget that we need the policy, the legal and the regulatory framework to get that right and to get that mix. Now, before I leave you all to get some of your own self-care. And I'd like you to imagine what that is, whether it is after this session, a few minutes to yourself, whether it's a yoga class. I want to turn to a Menti word cloud based on your breakout discussions. Use 1 to 3 words and we'll get this kind of glorious word cloud coming up. And you can use any language that you want to summarize why self-care is critical to universal health coverage. So what are the words that come to mind? And be creative in that and show everybody what you think. And Natalia from Tech Change has given us a link, I believe, that you want us to enter the word there. Is that correct, Natalia?
Yes, please click the link in the chat and contribute the words to the word cloud.
I'm seeing equity and empowerment, independence. Come on, we need more. Make UHC personal, I love that. More empowering. Self-care is daily life. It's our foundation. I think privacy is really important. Private sector engagement. It's about individual agency. So there's a lot coming out around the community empowerment that's coming out as part of that UHC and PHC, liberty, access and reach. And you'll see some of the words when they're mentioned again and again are, they get bigger. So if you want your vote for your word, individual agency, bodily autonomy, leaving no one behind. It's cost effective. There's a return on investment. And there is an evidence and learning working group that's looking at the financing on that. I'm doing a pitch in the word cloud for that, and they'll report on some things in September. Freedom, feasibility, everybody does it every day. Human rights. I just put that, leaving no one behind, opportunity, choice. Oh, I love these word clouds. Self-care is daily life. Excellent. I want to thank you for that. And we're going to, you can keep things coming in the word cloud. And I want to end with, I want to thank the organizers, the multiple agencies that were involved in organizing this session. And then of course, the White Ribbon Alliance. And we're going to end with a very short film on the end. So thanks to all who participated and the presenters and the organizers in particular for a fabulous session.
Quick note, there'll be an evaluation survey pasted in the chat.